Hello, and thank you for taking time to learn about the Maryland EMS protocol updates for 2025. I'm Dr. Tim Chismar, State EMS Medical Director. As a reminder, these changes to statewide protocols will take effect on July the 1st. Every year, EMS clinicians, physicians, and nurses from around the state help to refine protocols, add new ones, and remove others that have become outdated. In this segment, I will provide an overview of 5 protocol updates, which include general patient care, specifically pulse ox and patient refusal moving to the general patient care section, moving video laryngoscopy from optional to standard protocol, moving naloxone leave behind from optional to standard protocol, and updates to the high consequence infectious disease or HCID protocol, which was formerly called emerging infectious diseases. According to the scientific literature, pulse oximeters, which are used on a daily basis in EMS, may give falsely higher readings and are overall less precise in patients with darker skin color. Why is this important? These errors may lead the EMS clinician into a false sense of reassurance by limiting detection of low blood oxygen levels in patients with darker skin tones. While technological fixes are underway, it may take time for newer generation devices to reach the wider market. To address this issue in the interim, we are adding a statement to the alert in the general patient care breathing section. Currently, protocol lists hypothermia, hypoperfusion or shock, carbon monoxide poisoning, hemoglobin abnormalities, anemia, and vasoconstriction as clinical factors that may lead to inaccurate or misleading pulse ox readings. Protocol change for 2025 adds dark skin color to this list of caveats. Please do not be reassured by a normal pulse oximetry reading in a patient with darker skin tone who exhibits other signs of respiratory distress. Patient refusals and non-transports are some of the highest risk scenarios that we encounter in EMS. In these cases, the patient's assessment, treatment, or both are often incomplete. This may lead us to miss time-sensitive clinical conditions. However, patients who have medical capacity to make decisions should be afforded the right to do so. Since it is important that patients make informed decisions, EMS clinicians should provide patients with as much information as possible prior to signing refusal forms. Since this has been a very complex issue, Maryland's EMS protocols have had a patient-initiated refusal procedure for many years. There is a checklist that walks you through an assessment of the patient's medical decision-making capacity, followed by history, exam, and vital sign parameters. In some cases, medical consultation is advised. Importantly, the goal of medical consultation for refusals is for the patient to hear the physician echo the recommendation made by the EMS clinicians. It is not intended for the physician to approve the patient refusal. For 2025, given the importance of incorporating patient-initiated refusal of EMS into our daily work, we have moved it forward to the general patient care section. I think that you would greatly benefit by taking a few moments to refresh your understanding of the protocol. Since a checklist is provided, it is not necessary to memorize the protocol verbatim, but it is important to be able to locate the checklist quickly when you need it. Since the adoption of video laryngoscopy as a pilot protocol in 2013, several studies have examined whether video laryngoscopy improves the odds of a successful intubation as compared with conventional or direct laryngoscopy. Several articles cite higher rates of first-pass success with video laryngoscopy compared with direct laryngoscopy. Clearly, video laryngoscopy is an instrument to facilitate intubation. It does not replace the skill of an experienced paramedic. You should be aware that there are some potential disadvantages to video laryngoscopy. For example, secretions that can fog or obscure the camera. In light of the available research, however, video laryngoscopy will move from optional protocols and become a standard statewide protocol. There will be a phase-in date to allow for procurement of additional devices. After July 1st, 2026, all EMS agencies will be required to have both video and direct laryngoscopy equipment. Paramedics who have access to both modalities will have improved chances for first-pass success with orotracheal intubation. Approximately 30% of patients treated by EMS for an opioid overdose are not transported to a hospital. Additionally, about 5.5% of patients who are treated for opioid overdose die within the next year. While recent numbers show declines in deaths from opioid overdoses, we know that the opioid crisis is far from over. Local research shows that patients who received naloxone leave-behind kits, along with treatment resources, were 5 times more likely to engage with treatment and recovery specialists over the long term. Based upon this work, along with positive anecdotes from the field, most jurisdictions have already adopted the naloxone leave-behind optional protocol. The naloxone for this program is provided by the health department at no charge to EMS. Effective July 1st, 2025, this protocol will become part of the standard statewide protocol with an aim to expand access to all jurisdictions in Maryland. The modification to this protocol brings Maryland into alignment with the guidance published by the National Emerging Special Pathogens Training and Education Center, or NETEC, CDC, and HHS ASPR. Previously, our Emerging Infectious Disease, or EID protocol, focused largely on Ebola. And while Ebola is a concern from time to time in the U.S., there are other high-consequence infectious diseases that can cause significant impacts. The new protocol includes a broader approach to personal protective equipment, or PPE. It also provides guidance regarding transport to the regional emerging special pathogen treatment centers. These centers include the Johns Hopkins Hospital and MedStar Washington Hospital Center. Finally, there are no longer middle-tier assessment hospitals in the protocol. If the patient has a suspected HCID, they should be transported to the closest regional emerging special pathogens treatment center if transport time is not more than 45 minutes greater than the time it takes to get to the closest frontline hospital. In closing, I would like to thank you for your dedication to providing exceptional care for our Maryland patients. I also want to take a moment to give a special thanks to the Protocol Review Committee and your colleagues from across the state who are featured as speakers in the upcoming learning modules. I hope that you'll find the following updates clear and informative.